In 1978, at the International Conference on Primary Healthcare in Alma-Ata, 134 countries gathered to radically redefine global public health. For decades, medicine had been heavily centralized around reactive, high-cost hospitals treating acute disease. The primary healthcare framework sought to invert that structure, proposing a system rooted in proactive, universally accessible care delivered directly within the community. The ambition of this framework was massive. By focusing on essential health services like immunization, clean water, maternal care, and local disease control, this decentralized model was mathematically designed to handle 80% of a population's lifetime health conditions. Because it targeted the root causes of illness rather than just the late-stage symptoms, member nations formally adopted this specific systems engineering approach as the ultimate blueprint to achieve their goal of health for all. Yet, almost half a century later, the reality on the ground tells a very different story. Despite the widespread formal adoption of the primary healthcare framework, out-of-pocket medical spending still drives roughly 1 billion people worldwide into severe poverty. When community-level prevention fails, untreated conditions spill over into urban hospitals. Wards become overwhelmed, reverting the system straight back to the expensive, reactive triage that Alma-Ata was supposed to eliminate. The breakdown of modern primary care is a problem of systems engineering and resource allocation at the final mile. Health ministries consistently draft clean, top-down policy mandates, but those directives frequently fracture upon hitting the chaotic, under-resourced reality of community administration. To actually engineer universal health coverage, we have to look past the pristine policy documents and isolate exactly where and why the operational network is severing. A frequent administrative misconception assumes that expanding primary healthcare simply means pouring concrete, constructing more rural clinics, and staffing them with doctors. The WHO framework operates on 5 principles: accessibility, public participation, health promotion, appropriate technology, and intersectoral cooperation. True primary care operates as an invisible, intersectoral network. It requires integrating safe housing, agricultural nutrition, and digital infrastructure, reaching far beyond the walls of a single building. We can isolate the health promotion principle to see how this functions in a high-resource environment. The Montreal Dietary Dispensary Program provided targeted nutritional counseling to pregnant women in low-income brackets. A cost-benefit analysis of the program revealed that for every single dollar spent on proactive nutritional support, $8 were saved in downstream medical costs. Scaling that ratio up, a $6 million investment to cover all at-risk expectant mothers in Quebec would be entirely recovered within 14 months. This economic multiplier shows how the primary care model can transition from a reactive cost burden to a proactive economic shield when the health promotion node is properly integrated. To see what happens when that integration is starved of resources, we must look at the operational reality of low-resource implementation, like the Indian Public Health Framework. At the base of this national structure is the ASHA worker, the accredited social health activist. They serve as the vital human bridge tasked with executing the public participation and accessibility principles. The ground-level expectation is intense. These women are directed to personally educate communities, track family planning, monitor newborn postnatal care, and secure vaccinations for thousands. Achieving those metrics requires grueling physical and administrative endurance. ASHA workers navigate complex environments on foot, consistently logging 10 to 12-hour workdays. Yet, these frontline professionals are not categorized as full-time government employees. They operate on a piece rate incentive structure, receiving a base compensation of merely $50 monthly. Under-resourcing the primary human node of a decentralized network introduces immediate structural friction. A system designed to protect a population's health cannot physically function when the individuals driving it are themselves exhausted and economically unstable. This weakness is compounded by 3 specific bottlenecks that sever the network at the community interface. The first is the weaponization of appropriate technology. Health ministries frequently issue digital tablets loaded with location tracking apps, mandating extensive online data entry quotas. This forces the worker away from proactive community care, turning them into an uncompensated data collection node. Information regarding illnesses, infections, and testing results is continuously extracted upward to a centralized database. However, actionable medical solutions and physical resources fail to flow back down to the worker. That extraction leads directly to the second bottleneck, the failure of the essential drug supply chain. Workers are dispatched without supplies, missing calcium, iron, or safe delivery kits required for maternal care. Consequently, low-income patients are forced to purchase these necessities from expensive private retailers. This specific supply failure triggers a fatal psychological breakdown in the model. When a worker surveys a household for illnesses but has no medicine to offer, the community views them as an administrative nuisance, destroying the trust required for proactive care. The final layer of friction is sociological. Deeply ingrained caste-based discrimination and class hostility interrupt equitable distribution, preventing health workers from safely accessing vulnerable populations. The combined weight of these bottlenecks eventually fractures the system. Facing stagnant wages, lack of protective gear, and administrative harassment, the workforce strikes, bringing the entire primary care network to a complete halt. Mandating community participation without simultaneously engineering robust supply chains and basic labor protections guarantees the collapse of the primary care model. We can observe exactly how appropriate technology operates when deployed correctly by looking at a Canadian case study. The University of Ottawa Heart Institute uses a telehealth model to provide patients in isolated northern communities with uninterrupted 24/7 access to cardiac nursing consultations. A patient's health metrics are transmitted to the nurse, who then directly guides the patient to adjust their diet, modify their medication, or connect with a local professional. It is a completely bidirectional flow of care, in sharp contrast to the extractive surveillance apps forced upon ASHA workers. Deploying technology purely to harvest administrative metrics from a population without returning tangible clinical value exhausts the community and hollows out the workforce. Within the primary healthcare framework, technology is only appropriate if it actively delivers care and empowers the patient at the endpoint of the network. Looking at our architectural map, the required repairs are clear. We must convert extractive data lines into bidirectional support structures, instituting fair compensation and unbroken drug supply chains. Reducing surveillance bloat removes administrative friction, allowing health promotion and accessibility to function as designed. Universal health coverage is mathematically impossible without a properly protected, respected, and resourced community interface. Health ministries that treat their frontline workers as cheap data gatherers while starving primary health centers of basic infrastructure will inevitably default to fragmented, heavily privatized, and deeply inequitable care. When engineered correctly, the system sustains its population from the ground up, identifying and neutralizing health threats before they ever require a hospital bed. A functional primary healthcare system requires a bidirectional network engineered to support its frontline.